to move very quickly, I don't want to lose this opportunity to recognize all of you, and I do mean all of you, who are here, who are making amazing things happen, who are caring for our patients, caring for each other, and showing an incredible resilience and commitment. When I see this, and when all of us see this, and the sacrifices you are making, we can only give you our most heartfelt thank you. Our community is also recognizing all that you do, and I'll share some activity on social media regarding our front lines with #tag Hail to the Front Lines posts. But regardless of your area in the organization, whether clinical, support, academic, or administration, thank you all for your contributions and your sacrifices. Much of the activity over the last week, and you'll hear about this, has been related to ramping up our ability to care for more patients. We began taking transfers from other regional hospitals who have exceeded their capacity, and we've created additional units outside the RICU to be ICU and ventilator capable. This has been no small feat, and the rate at which this has been done has been nothing short of incredible. And I want to thank also everyone for their willingness to throw in and make this happen and rise to the occasion. We anticipate that things could become more challenging in the next few weeks. Given the transmission rate in Michigan and the overflow from other hospitals, we expect the COVID-19 situation could get worse before it gets better. Today, you'll hear much about our plans to create greater capacity to care for both ICU and non-ICU patients. What I'd like to stress, though, and you'll hear from Dr. Spollinger and others, and Dr. Desmond, many of the decisions we're making are made on a daily basis, and they're informed by data that is coming in every day, every other day, and it's informed by data here in our hospital and other hospitals and what happens in the community. I think that the governor's directive on social distancing either has already or will be extremely important as we try to flatten the curve and reduce the infection rate in our area and across the state of Michigan. However, our planning activity is absolutely critical. We need to be prepared for the worst, but our hope is we don't encounter the worst and we don't have to implement everything that you'll hear about today because we will see the impacts of social distancing, the stay home to be safe executive order, and other ways in which people are protecting themselves and their loved ones. Before we move on to various updates, I want to emphasize that we'll recognize that this is a really stressful time for all of you, for all of us. And many of you may be aware, but if you aren't aware, there's a COVID-19 stress response team which offers support and consultation in times of heightened stress. Am I supposed to be advancing my slides? Here's the Hail to the Front Line. This is just two of many photos. And if you haven't seen the video on thank you, it is really moving. So these are the resources for the stress response team. These slides you'll receive as you have previous slides, a phone number, as well as a donation website for those of you who have PPE or other resources you'd like to donate, or you have friends who have those. We all have several different pain points, but I think what I'm seeing and what we can do is support each other during these difficult times for ourselves, for our families, for our patients. Our leadership team, is committed to doing all we can to provide support and resources that will help all of us get through this crisis. We believe in you. We trust you. We've seen how this pandemic, as unfortunate as it is, has brought out the best in you and your tireless efforts. Now Jeff Desmond will speak to some of the projections about our census in the coming weeks. Jeff? Sorry. I left my mask. Somewhere. Oh, my mask in my pocket.
Thank you, Marshall. I'm Jeff Desmond, Chief Medical Officer for the health system, and I'm going to talk to you about a couple things, updates that we have both on the national level, regional level, what our experience has been here, and then to reiterate what our principles and the phases of our preparation have been, highlight a few of the things that we've done and kind of give you a sense of our next level of preparation. So these slides you've seen very much before this, these are slides from the Johns Hopkins coronavirus map. This is as of 9:30 this morning, and you can see 245,000 patients in the state of Michigan, or in the United States. If I look carefully, I can see it says 10,791 in the state of Michigan. So Michigan is fourth in the nation, and you can see the distribution there. This is a zoomed in view of Michigan, and if you can see on the right-hand side, Washtenaw County has 438 cases, and so is fourth in Michigan, behind Wayne, Oakland, and Macomb County in that order. This is what our dashboard looks like in the command center and shows you where we are now. So we have had 178 positive patients in the hospital now. You can see the map shows that the predominance of those positive cases in Michigan are in the southeast part of Michigan. We currently have one positive pediatric patient, and you can see that we have 83 of our positive patients are in intensive care. And I'll talk a little bit about that because we have focused initially on expanding intensive care and taking some transfers from the Detroit area hospitals of their sickest patients to offer our services to those that need it. I will say that since we started, and I'll remind you that on March 10th was our first positive case, and we, over the course of that time, we have had 10 deaths in the hospital related to COVID. That said, out of the 271 patients we've had, 84 have been discharged home to this point. And so and we've had 25% of our patients who required ICU level care being discharged home. The graph on the right shows you what our number of cases per population are compared to some other models. And you can see that we model the 5 counties in the Detroit. So if you model the 5 counties in southeast Michigan with Detroit, you can see how steep that curve is and how that compares to the New York experience. You can see that Detroit is a significant contributor to that because if we model the 5 counties without Detroit, it flattens it out a little bit. And if you look at the rest of Michigan, you can see that the curve is even flatter than that. And this is number of days since first cases and cases per million population. If you look at what our projections are, and we look at these projections frequently because we want to know how our modeling is predicting where we need to be and how close we're tracking to that. As Marshall said, we are making tremendous preparations to be prepared and to have adequate capacity, and we've been successful in doing that. So we look every day or every couple days at the projections and say, are we on track? Do we need to make different decisions? What do we know that's happening in the environment around us that might allow us to make different decisions? And you can see where we're tracking. One of the specific decisions that we made was to take transfer patients from hospitals in Detroit that needed our help. And we took a number of those transfer patients, and that has modified our model a little bit. So this shows you that. If you look at our curve, which is this blue line, compared to 3 other models, the model for the country of Spain, the state of New York, or the state of Washington, you can see that that if you take our transfers out, we track pretty closely to that model. And this is what the line of our transfers look like when we started to increase those transfers from other hospitals and other emergency departments. If you add those together, it looks like we have a steeper trajectory. So we've been able to help out the area of Detroit and surrounding hospitals by taking some of their sickest patients, while also keeping capacity for the number of patients that we think are expected to come here, and we're planning for that. Our principles and our core principles around planning for this pandemic have been these: that we initially reduced clinical capacity so that we could have a capacity to provide care for the COVID patients while still being able to provide essential care for those non-COVID patients. To really focus on increasing ICU capacity, and I'll talk to you a little bit about that specifically. To take a system view and to look at all of our resources across both of our hospitals and what it would need across our health system to be able to be prepared and appropriately respond to the patient need. And then just a point, and everyone has said this, and I'll just reiterate it again, the recognition that none of these things have been easy, that we recognize the hardship, we recognize the effort that it takes to do this, and we would not be where we are today in our level of preparation without the unprecedented collaboration and flexibility that we've seen across the organization. And I know that sometimes it's been frustrating. We've had one priority, and then things have changed around us. We've had newer, different information, and it seems like we've changed priorities or changed strategies sometimes. Some of that's been communication, but sometimes that's just the change in the environment around us and the need to respond to that and be prepared. So we really appreciate everybody's effort, everybody's flexibility, and certainly the collaboration that we've had when we've been making these plans. I'll walk you through kind of just the phases of our surge planning, and I would say, as I did in one of the earlier town halls, we really started with kind of phase 0, which was our pre-planning and watching this develop in Wuhan, China, and make sure that we had thoughts about how to prepare. But really phase 1 was creating capacity here within the hospital, and we did that by kind of reducing what I've called here routine activity. We did activate the RICU, and then we had focused our COVID patient care in the RICU and in other appropriate rooms within the hospital. As we started to get more and more patients, we've extended COVID care beyond just the RICU and have been cohorting COVID patients as best we can and made efforts to move vulnerable populations to different locations in the hospital. Again, a big lift and a big effort from those teams to move around, but also in an effort to keep our patients safe and to provide the best care that we can. I'll really talk to you more about where we are now, which is really phase 3, which is the continued development and expansion of ICU and ventilator related care so that we can have enough resources to be able to meet the patient demand. And that we would expect a majority of our adult hospital is going to be related to COVID related care. That said, we're also cognizant of there is an underlying need for necessary care that's going to take place that's not related to COVID, and we need to have capacity and the ability to do that, and we're managing that. And then phase 4, others will talk to you about, has really been our thought about how to manage outside the walls of our hospital. This looks like a long laundry list, and it is, but I'll also tell you that there is nothing on this list that has been easy to do, and I'll walk you through these fairly quickly. So we have completely redesigned and centralized and streamlined our transfer process, and that's allowed us to make better coordinated transfer decisions. And again, as we've talked about, take some patients from other hospitals. We've enhanced our transfer process and the utilization of our partner Chelsea Hospital so that we can maintain access to some surgical procedures and be able to move patients there. As I talked about earlier, we've moved vulnerable populations in the hospital so that they are in locations that provides them a higher level of safety. We're taking an enterprise-wide approach to our staffing and redesigning how our care teams are deployed on hospital wards. And I'll talk to you a little bit about this super unit structure that we've talked about. That really will allow us to successfully deploy unit-based teams, and that allows us to manage that workforce even in the face of a potential dilution of the workforce from either absenteeism or illness. We've implemented a plan of the day communication that after our first huddle in the command center, we send out a plan to all of our M-Plan partners, their clinical nursing directors and medical directors for the units, so they know kind of what the activity's been in the last 24 hours and what's the plan for the patients that are coming in for that day. We've continued the necessary inpatient care that is unrelated to COVID. We have continued to increase our testing capacity. And then we've implemented a masks for all policy. And a week ago, that was masks for all employees. We're going to expand that now to all that are entering our facilities to enhance that level of safety. Others will talk to you about phase 4 planning. And then I'll just say that in addition, many of our leaders have started to think about what's the phase 5 planning when patients have left this hospital and convalescent care that they need and care that they may need as they recover from COVID outside the hospital. I have just 2 more slides that I'll walk through. And the purpose of this slide is just to show you that our plans will allow us to increase our ICU capacity from around 100 beds to over 250 beds. So a significant increase in our ICU capacity. And that really involves units from across the organization, including contributions from the Children's and Women's Hospital and being able to use an intensive care unit there for adult patients. And again, this has been just great kudos to those who have been leading both the ICU redesign care, which has really been Dr. George Mashur, our chair of anesthesiology, and now Hassan Alam. in general surgery who have taken on that role and done a phenomenal job of putting those teams together. And also to Scott Flanders and Vineet Chopra and those in internal medicine who have really worked to redesign the hospital care teams as well. And I'll finish with this. This is kind of our the general care and critical care super unit model. So I think many people know we have A, B, C, and D units in our adult hospital. So we're really thinking about those A and B units as a super unit together for provider and nursing staffing to be able to allow unit-based teams in a general care sense, and then those C and D units together to provide intensive care. And as we imagine, as we have increasing care demands from the patients, we can bleed out intensive care and moderate care onto those C units and be able to elevate that level of care that we provide in those areas. Again, all the time maintaining adequate space for our non-COVID care patients that we know have necessary care. So with that, I'll finish, and Keith Dickey will take over and talk about our phase 4 planning. Thank you.
Jeff, thanks very much. Yeah, as Jeff noted, we've been doing a ton of work to expand capacity within the 4 walls of our hospitals. All the while, a lot of thinking and planning has been going on as well around what we're calling phase 4. In the event that we need to create additional capacity outside of the hospitals and what that might look like. So there's been quite a lot of work done. The goal here really is to create safe capacity for the overflow of general care, lower acuity COVID patients from UH to an off-site location, a so-called field hospital, in order to allow that much more capacity for UH to take care of the most critically ill. The concept here is that we would be looking to transfer lower acuity COVID positive patients from the UH facility to a field hospital. And I apologize, I'm going to go back for a second. We evaluated a whole number of sites. In the end, we landed on the indoor track facility at the South Athletics campus, and you can see that in the picture here. And the concept then would be to transfer lower acuity COVID patients that are clinically stable, have a low risk score for deterioration, and certainly need oxygen, but not ventilation, and requiring minimal medical monitoring. And needless to say, we have some other exclusions that would need to be implemented as well. And this patient cohort is constantly being evaluated and reevaluated as things evolve. The notion for the time being is that this field hospital would essentially serve as a step-down unit from the general care wards of UH. However, we've also been planning for the possibility that we may need to receive patients directly from the ED in the event that the surge is greater. And so we're thinking through that as well. As conceptualized, this Michigan Medicine Field Hospital right now would be a 516-bed negative pressure facility in that track facility. And of those 560 beds, 16 beds, we'd have about a 20-bed, sort of what we're calling a moderate care pod for a subset of the patients that might need more room for more intensive care. We've already set up a command center there, and we're ready to activate that command center and link it directly to the UH command center. We will have the ability to provide oxygen supply to all of those beds with full flow capabilities as needed. We've conceptualized an on-site pharmacy with a targeted formulary, and we've been thinking through the ancillary services that will be required. We think we can bring MyChart to the facility, certainly for registration and perhaps light documentation. And we have confirmed that we can turn that facility into a Michigan Medicine network so that we'll have Michigan Medicine workstations, we'll have Michigan Medicine wireless and network, and we won't have a VPN situation there. And clearly, we're going to need dedicated bidirectional transport from that facility to and from UH. One of the really exciting developments just in the last 24 hours or so is that we've gotten engagement now from FEMA, MDHHS, and the Army Corps of Engineers. The Army Corps came out and evaluated the field track site once already and gave their thumbs up approval for consideration of this as an official alternate healthcare facility. They'll be coming back with a number of other agencies on Monday to do a deeper dive. And we are working then to seek the approvals for this to potentially become the third alternate healthcare facility in Southeast Michigan. Many of you know there's one that's being stood up in Detroit at the TCF and another in Novi at the Suburban Showcase Center. So we're exceedingly excited and look forward to understanding how FEMA and their resources can help us with that. For the moment, we've just been doing our own planning. We've gone through an exercise of conceptualizing what this facility might look like and doing some mock-ups of bed pods. We've conceptualized it along the lines of this grid. Clearly, if the Army Corps is going to come in, these plans may be superseded then by what they think and do and can bring in terms of their resources. But for the moment, we're working on a plan assuming that we don't get more support. We've stood up a full leadership team for this field hospital, and I won't go through all of the names or boxes here, but we have physician leadership led by Drs. Don Coleman and John Eliason, both of whom have military backgrounds. On the nursing side, we have Sue Ann Bell, who has DMAT, Disease Medical Assistance Team experience, and actually just came off a federal deployment to a COVID quarantine site on the West Coast, as well as Jesus Shapiro, leaning in on the nursing front, and Luann Ewald will be leading the administrative leadership for this team. And we have a host of others who have been working round the clock already for over a week now to start to define what will need to be true for us to successfully stand up this field hospital in the event we need to. And with that, I'm going to turn it over to Dr. Mulholland to speak with you a bit about the staffing needs if we are to pursue this. Thank you.
Good afternoon. I'm Mike Mulholland. Thank you for attending the town hall, wherever you may be. As you have heard, we may need to set up field hospitals to care for COVID-positive patients if our inpatient units become full. If this happens, we'll need the talents and dedication of everyone, and there will be roles for everyone to step forward in a positive way. We need you if you've been in the military and have experienced work in a field hospital. If you're trained in BLS or ACLS, if you can help patients arrive and then triage them. There will be a big need for general medical care, particularly pulmonary care. A few patients will need procedures like placement of lines and chest tube insertion. While we expect that most patients will be steadily recovering, some may deteriorate and need emergent or critical care, and we'll need a few people with those skills. Many patients will be weak and need rehabilitation. Some will need palliative care, and those of you with this training experience will be welcome. For the rest of us, we can help by providing support, caring for patients teamed with others of greater experience. I place myself in this category. I have volunteered to staff the field hospital from the first day, and I'm asking you to consider volunteering as well. The work will be difficult. For most of us, it will take us far away from our usual comfortable lives. We are used to order and predictability and the luxury of plenty. A field hospital will have none of that. Many will rise to this occasion with new leadership. I believe this service is best approached with a deep sense of personal humility. Over the coming weeks, our work will require courage from all of us in all of our work. This courage will allow us to care for others, knowing that in turn, we will be cared for, and our families cared for in the same way should we become ill. We'll get through this together, I promise. Thank you.
Good afternoon. My name is Nancy May. I'm the Chief Nurse Executive for the health system. And I truly appreciate Dr. Mulholland's message. I think many of us are going to be stretched in different ways We talked a little bit about the nursing model last week, and how we were working today is going to look different tomorrow. So we met together, the Nurse Executive Council. I really need to give a shout out to Kelly Baird Cox, Julie Grinwald, and Francine Lundy, as well as Pat Poza, who's one of our staff specialists, who have really been diligently working on putting a staffing model together. We heard from Dr. Desmond the challenges we have ahead of us with our ICU care that we will need to provide for our patients as the surge of patients enter our health system. We build a model, and it's off our guiding principles. This model will be starting on Sunday, the night shift coming in Saturday night into Sunday. And as we looked at our guiding principle, it really was about employee and patient safety being the highest priority. The next thing I just have to stress is that nursing as a whole has been in our silos. We've worked in our children's hospital, we work in the PACUs, we work in the ORs. Our case managers work across the house, we have home care, but this is really a call to action for our entire nursing community to come together and provide the care that is needed for these patients as they come into our health system. The other guiding principle really is about providing the best care we can to our patients and to support and advocate for all of our staff during this vulnerable time. This is scary. Let's face it. We have a new challenge ahead of us, and we have to take care of ourselves in order to provide the best care we can. And so how we come together as a nursing community to support each other as well as our patients is really what this is about. It's all nurses, all assisted personnel, and all roles, and all hands on deck to help us get through this. We started to build a model, a new staffing model to take care of the surge of patients as it comes in. There's going to be 3 models of care that are outlined here today. One is an ICU care model that has 3 ICU nurses, a complement of a general med and tele nurse, and an assisted personnel to manage 10 patients. We've started moving into this model of care this week to see what we can do differently, what is working, and other modifications that will need to take place as we move forward. We also will have a case manager and social work embedded in that. And this nursing staff is also complemented with our physician staffing, as Dr. Desmond had talked about. So this will be the ICU care that we're working on in our current state today as we move models forward. The general care and tele units look a bit different as well. We'll have a team approach as well in this model, where one nurse will have a team of 6 to 7 patients in her team. She'll also have the clinical support. It could be a tech, it could be an aide, it could be another nurse from ambulatory care that has not been familiar with the inpatient documentation, or the how to manage an inpatient unit because they've been out of that arena or never worked within our health system. In addition, there'll be a charge nurse that is on the unit, case management and social worker to support our patients and families, as well as respiratory care available. And once again, we're complemented by our strong medical team provider. As we continue to fill ICU beds, we'll have to continue to look at staffing and stretch it a bit differently. What we have had to do is do some just-in-time training for nursing. Another shout out to our professional development teams that have done many, many toolkits. They've worked with our clinical nurse specialists as well as our nurse educators to build skill competencies as well as to develop confidence with the staff moving forward as they transition into new roles and new areas. What we've done is developed a core set of nurses for each floor. In addition, any additional staff has been redeployed to a central staffing resource pool. The central staffing resource pool is building schedules. We're hopeful to have those done today. And nurses that are in those resource pools will get a call and get contacted in regards to where they're going to go. For areas that work at UH, CVC, if you are one of the core members of your team, and you get sick and don't feel well or can't get to work, there's one number, it's a new number. So I want you to take a look at it. We tried to make it as simple as we could. It is 734-232-6000, and call in so that we can redeploy another staff member into that area. A shout out also needs to happen to our nurse recruitment and retention team. They've taken many volunteers' names that have come forward to me over the last 2 weeks that want to help with our field hospital. And so Gwen Curley and team are working at taking a look at the nursing people that are volunteering to work and making sure their licensure is up to date. They're also helping coordinate with our HR business partners to ensure that anybody who's volunteering or needs a place to work, if we can redeploy them to the field hospital, they will be hearing that in the days to come. I just would like to end by saying the past few weeks have brought unprecedented challenges for our teams and prompted dramatic changes in our system. So many of our employees have come through with amazing dedication to care for our patients and to keep each other safe. It's hard to express in words how much gratitude, flexibility, and your leadership for all the work you've done and what we've accomplished in such a short time, but yet have so much more to accomplish in the days ahead of us. Once again, our employees and teams across the organization have worked together collaboratively on innovation solutions and made sure that safety of our patients and employees is a top priority. We will come together as a nursing community and we will be stronger at the end of this. I know that I can count on you to continue to support each other, the people you work with, as well as our patients and families. I can't thank you enough. Now we're going to close with Dr. Spollinger.
Good afternoon. I want to correct something I said last week. We had about 200 questions the last 5 minutes of the town hall, and I said that's all the questions. That was what I meant. That's all the time we had for questions to answer. We will continue to look through all the questions and put answers out in the daily briefings that we have coming out of the command center. So if we don't get to your question today, we will answer it. We do have a large number of questions here, and I think I've got them put together per person, but I may not have completely got it, so I may ask you to come up twice. I think, Lorraine, I'm going to ask you to come up first. There seem to be a lot of questions around infection prevention, So the first question is work being done to sanitize and reuse masks?
Right, so that's a really good question. You may have heard that many other health systems are beginning to reprocess masks in various different ways. We're really lucky because we work in an institution that has a lot of experts, including engineering experts and virologists, who have been working very hard on a process to validate using UV light and moist heat to decrease the amount or eradicate virus from the masks so that we can begin to use our masks for longer periods of time in a safe way. And we expect that that's going to be rolled out very soon. I can't give you an exact timeline, but I would say I would be surprised if we weren't doing that by Monday.
The other question is, will we have enough testing capacity to test all healthcare workers or high-risk workers?
I think we'll have enough testing capacity to test all symptomatic healthcare workers. We're really committed to being able to provide testing for anyone who is our employee who has symptoms which are potentially compatible with COVID. I know there's been a lot of work to improve the way that we can gain access for employees to testing, and occupational health has put a tremendous amount of resources into doing that. And I know that we've tested a number of employees already and will continue to do so.
You want to say something about the sensitivity of the test after exposure? That may be a corollary here.
Okay. So I think there was a question about when should people be tested after they might have had an exposure to COVID, and in particular, an unprotected exposure to COVID if they weren't wearing a mask or potentially wearing an N95 mask during an aerosol generating procedure. Really, the same principle applies, that we would really want to test people if they become symptomatic. with fever, respiratory symptoms, or dyspnea, the sensitivity of testing someone who is not symptomatic to determine whether they have infection is not as high as testing someone who is symptomatic. It's a bit hard to understand because we're now hearing that 25% of all people who are infected with COVID actually have no symptoms. But after you're exposed, we really need to wait to determine whether you're coming down with infection until you have symptoms, because I think we would otherwise have to test people every day to determine whether they were going to develop the virus ahead of, or develop infection ahead of symptoms, and that's really just not practical.
What protocols should a potential COVID positive provider follow when entering their homes with families?
I think I had this question last week, and so maybe my answer wasn't appreciated, but I think I still have the same answer. The best protocols, I think, are really common sense protocols, and I'll start by saying that the main way that COVID is transmitted is by droplet transmission, and that's infectious respiratory droplets that can enter your mouth, nose, or eyes, and that the contribution of fomites, particularly cloth, where the virus does not survive as long, and it's really not clear whether you can transmit the virus from clothing or not, is, if anything, a very small contribution to transmission. That said, I know that people are very worried about bringing virus home to their families, and I would still say that the best practice is to wash your hands when you're leaving work, to go into your home, take off your shoes, put them away, and quickly change your clothes into clothes that you're not, to new clothes that you're not wearing at work. Usual practices such as laundering your clothes with hot water and then drying them in a dryer to further kind of heat the clothes are effective at killing the virus on clothing, and so that would be additional method that you could use to provide a sense that you're doing all you can at home.
I think that's it for you, Lorraine, unless I read this wrong. Jeff, so the first question is, can I bring my own N95 mask to wear at work? If no, why?
So we have adequate PPE supplies currently to provide PPE for the appropriate situations in which people would need an N95 mask, and that is for the aerosolizing procedures. There's a risk to bringing in N95 masks that either aren't approved, may not be effective, are not fit tested, or may not have the integrity that medical grade and medical supplies might have. So I would say that the reason that we are not supporting people bringing in their own masks is that we don't have any evidence that that's safer than using the hospital supplies that we have now.
Is the hospital experiencing medication shortages such as albuterol, fentanyl, propofol, et cetera?
So it's an excellent question. One of the things that we've talked about related to our modeling, and when I spoke earlier, I talked about kind of the three constraints that we think about, and I didn't really talk about the three constraints today because we were pulling them all together in that model of care, but we still look at those, and those constraints are people, places and facilities and stuff and equipment and stuff, and I would include medication in that. So we've actually been looking ahead to say, what's our utilization of sedatives, of supportive medications, of analgesics with the number of patients that we have now, and how do we need to think to get ahead of that with increasing numbers of patients expected. So we are looking at that. We currently do not have any shortages. We currently know what our line of sight is on the amount of supplies that we have. There's a possibility, though, with a large surge of patients that we may need to modify some of our care protocols in order to use different medications, maybe particularly for sedation in ICU patients, to be sure that we're able to provide the medication over the duration of the pandemic. So we're ahead of that and looking at that. The other thing I would also add is that we have a number of teams across the hospital that are looking at this, and I would really point out that some of our vascular surgeons and those that have expertise around venous thromboembolic disease have started to look at how to change care protocols so that we can reduce exposure to staff, and have safer plans of care in terms of preventing complications like blood clots when patients are in the hospital. And so we really appreciate the work that people are doing to look ahead and help us be prepared for the patients that we would need to care for.
The other question is, how many frontline staff are COVID positive and how many have died or recovered?
So I don't know that we know those exact numbers today. We have, at this point, and I will not quote the numbers because I don't have them in the back of my head, and I'm not going to tell you something that I don't know is true. But we have had employees test positive for COVID. We don't have all the data to know if they're direct facing employees or not. The other thing that is hard is to sort out what someone's exposure is, and was this work-acquired COVID or is this community-acquired? We know that there is community transmission, and so those things can be difficult to sort out. That said, we're committed to the safety of our employees, and occupational health, as Lorraine has said, has done a phenomenal job of ramping up services and resources, and we're trying to get, we are getting to the bottom of that question.
One other question, are employees who have tested positive for COVID being requested to return to work? You know that?
Not sure I understand that question. So are we
After
asking?
14 days or after they've recovered,
So our policy, and I honestly don't know if we've had a patient follow this, is that if someone tested positive for COVID, they would be, and we answered this question, I think, last town hall as well, so hopefully I answer in the same way. But if you're tested positive for COVID, you would be out of the hospital for a minimum of 7 days, or as long as it takes for you to be asymptomatic for 72 hours. So that would be the longest of those period of time, and that's a consistent policy across many hospitals in the country.
okay.
Thanks.
Nancy? So the first one, will nurses on immunosuppressive medications be deployed?
No, they will not be. We are trying, obviously, to keep our nurses that are pregnant, breastfeeding, immunocompromised out of the hospital where COVID patients are. So we've been working with HR closely and trying to get those nurses redeployed into other areas. However, if there are not enough places to redeploy them to, they will be able to use their 80-hour PTO allotment for COVID issues, as well as the new ones that came out through HR this last week, which is an additional 80 hours.
The second question is, all nursing moving to 12-hour shifts? What if someone cannot accommodate a 12-hour shift?
So we are going to do our best to, as many people that can work the 12 hours, we will, because the model works best that way. However, I am very sensitive to the needs of our nurses, and we will do everything we can to accommodate the 8-hour shift for people who just cannot do 12. So we have asked the one-offs that can't move into the 12 hours to work with their local leadership, and we will try to work with them in order to accommodate our employees. They're valuable to us, and we need all hands on deck. We'll do our best to accommodate.
And the question is, can you elaborate on the plan for APP deployment? What will this model look like?
So the APP deployment will be embedded with our providers, because they are providers of care, and they will be partnered with the physician teams in order to optimize care in our ICUs as well as our general care areas. Some of our APPs, I do believe, will end up in our field hospital. We have a lot of APPs here, so we're very lucky in that respect, especially in times like this when we need to spread our resources very across various settings. And so as the field hospital opens, I would imagine a lot of our APPs will also be providers of care in that setting.
I think the next set of questions are going to be related to the field hospital, so I'll start with Mike, and then if you need Keith to answer some of these, call. Thanks, Nancy. The first one is,
And maybe that Keith would answer, why was the track facility chosen over other options? I don't know, is that Keith or you think?
I think that maybe Keith would answer that.
Yeah, why don't you come on up, because I think this would be the one of these. The rest are about deployment.
Yeah, we really evaluated two possible approaches. We looked both at a dorm option, and we are assessing a number of dorms to see if that might be a possibility for offsite care. And then we are also going through an evaluation process with various big space sites across the campus. The track and field was chosen as the most appropriate big site because it's newer, the HVAC, the air system, the ability to turn it into an entire negative pressure space were all really compelling. The surface was appropriate in terms to be able to lay down a proper flooring. So for a whole host of reasons, that made more sense than any other of the big spaces that we evaluated.
Okay, that's probably the only one. Who will be deployed to the field hospital? Is it voluntary, mandatory redeployment?
So thanks for that question, Dave. And I'll limit my answers to the physicians, faculty physicians, physicians in training and as residents and fellows, and medical students, physicians, training people training to become physicians. Nancy's talked about the nursing and APPs, and for the other areas like respiratory therapy and dietary, I'm just not qualified to answer. As we're currently planning, we're not planning that residents and fellows will be part of the complement to go to the field hospital. If that changes, I'll let people know, but that's not currently part of the planning. The direct answer to the faculty is deployment is mandatory, but my hope and expectation is that it'll be volunteerism. All 20 department chairs met last night, and they were given a homework assignment due on Saturday, and that is to characterize the skills of all of the clinicians in their departments. For example, have they been in the military? Do they have skills related to triaging patients, to general medical care, to performance of procedures, to palliative care, to rehabilitation? Can they be support? I mean, can they do the things that are required to help patients in their daily lives or just to move patients around and so forth? And when you think about it in that sense, I think every physician can help in some way. I will also tell you that I know today that there are a number of departmental rounds, faculty meetings going on. I know for a fact several of the department chairs will announce at those meetings that they themselves have agreed to be deployed. It's my hope and it's my belief that the positions will be filled by volunteers. I also want to tell you about an effort with regard to medical students. There are about 125 medical students that have volunteered themselves to participate in medical care. They're being organized by Drs. Deb Berman and Joe Kollars, but the impetus was from them. And I think that they may well be helping out at the field hospital. And I just want to say how incredibly grateful I am for that. This is a sort of altruistic stepping forward that motivated many, many of us to go into medicine. I'm really proud of them.
So I'll just add to that, because I've talked to Nancy, which is nursing students will also be able to volunteer for the field hospital, and that was the next question, is whether medical students and nursing could volunteer, and the answer is yes. The next question is, how can I volunteer to help? Is there a central office?
Yes, you can, any physician listen to me right now or later, you can send me an email. Or you can send it to Drs. Don Coleman or John Eliason, the two physician leads for this. They are both military veterans, both deployed in combat field hospitals, both experienced in Iraq and Afghanistan. And there's no two better qualified or more idealistic people that can help, if you send them your name, we will find a way for you to help.
How are mental health services being considered for deployment?
I'm going to say that I'm not sure about the answer to that, and I will find out, but I don't know the answer to that right now.
And will non-clinical staff be redeployed to assist with these efforts?
I'm going to ask Nancy to get that one. Do you have any other?
I don't have
ones
any
for
more.
me? Okay.
Mike?
I would just like to say a couple of things. One of the things we do in the nursing leadership team and our clinical nurse specialists, we have a call every day at 12 noon to give people brief updates. And one of the asks that I have continually put out is if we have any military nurses, and I am so proud of our military nurses because they are experts in logistics of moving people and populations in the military that work in field hospitals. And we have had 10 nurses volunteer to help in this field hospital. They will be pivotal to the success of the work that is happening. And so a shout out to them. If once we get to know all of our nurses that are doing the field hospital work, I think, on our Veterans Day and things, as we put out names, we'll have to really acknowledge those people. We also have people that have military background that continue to reach out to me, and we have means in which we connect those people. So Gwen Curley for the nursing piece or clinical piece, it has contact nurse recruitment and retention. They have a running list, and for those that are want to help out, I believe Darcy Hogan HR is compiling that list. And so the people that have reached out, I've even had people that are outside our own health system that want to help. And so the outcry from the community, our regional areas, it's been just humbling and just amazing to me. So, this is the time when people just rise, they want to help. And, even our nurse practitioners, many of them have also volunteered to serve. And regarding about mandate, we have said that it's all hands on deck. So we asked for volunteers first. And then we did actually look at people that had not volunteered and had some one-on-one conversations. And many of our ambulatory care sites, so Julie Ishak has done a great job getting people to volunteer and help, as well as identifying those other nurse practitioners that can help out. And so I think we have a good pool of people that we can draw from.
Okay. Tony, I just have a couple questions. So the first one is, what options are available if I want to request housing either to quarantine or not to return home after work?
Thank you. We've created a housing plan for employees who want to have respite housing for reasons why they don't want to go home for safety purposes. We have about a dozen hotels or university properties that we've arranged, and the process is to build off our patient visitor accommodation program. So it's 936-0100 or 60100 for the 5 digits to make a reservation. There's a process that you go through with your department and your manager in order to validate that request so that we can then provide a space for you. And currently it's up to 14 days for the initial reservation, and then we evaluate during that 14-day period if additional time is required. We also have about a dozen hotels that are reserved for quarantining, built off our hotel area network. We would go through the same process, and we would facilitate that through the same format. So there are many spaces available, and we're really grateful that we have the partnership with different properties in the community that are stepping up to help us out.
Who can I contact regarding COVID-19 bank time, PTO use, et cetera?
You start off with your supervisor to contact related to the COVID bank use. And if you have any questions beyond your supervisor, you connect with human resources.
That's all I have. I have some unusual questions. One is related to stores are out of cleaning supplies, and they're asking if whether employees can purchase from our supply. We do not have a process for that. I think I will we will come up with an answer as to what you can use at home, whether it's vinegar, what concentration and alcohol, and see if we can send that out. The last one is, do you anticipate furlough employees and cut salaries? To be honest, we have, like similar to Trinity, we have not discussed this at all. I think all our planning and all our energy has been in trying to come up with what we can do to meet the needs of patients. And I can honestly say we have not had this discussion in any of our leadership meetings. So at a later date, we'll maybe consider this, but I don't, at this time, we just got too many other things to think about. Finally, I just want to thank everybody for, I'm getting the sign that we're almost out of time. And I just want to reiterate today, Eisenhower said that plans are worthless, but planning is essential. So we have worked on planning with the idea that we need to be prepared ahead of time for the worst. We will make daily decisions and modify our plan based on the best available information at that time. I know at times this is frustrating that it seems like we're changing priorities or changing our plans, but it is based on new information in the environment. And we are meeting twice a day, and we make modifications to our transfers, to where we're going to put patients, where we're going to allocate those patients. So I think I ask for patience as we move ahead, and we will keep you updated as to what our plans are. But it's much better to be well prepared and not have to pull the trigger than to pull the trigger while being unprepared when we're unprepared. So thank you for dialing in, and have a good week and be safe.